Hello, I'm Umair Khalid. I'm one of the social media editors at JACC Cardiovascular Intervention, and it's my great pleasure to welcome Professor Tarantini for this interview. Thank you so much for joining us today.
Thank you. Thank you. Pleasure.
So today we are very happy to feature your publication titled The Coronary Access After TAVR CAvEAT Study. It's a prospective registry of coronary access after TAVR. So with the growing global adoption of TAVR, coronary access after TAVR has become a very hot topic, as you know, in both clinical practice and research interest as well. So your research is very valuable to the audience. So could you walk us through the design of your study and specify what types of TAVR valves did you include in your analysis?
Okay, perfect. So first of all, thank you for having me. It's a big pleasure to be here. So as you said, the CAvEAT study is a prospective multi-center conducted trial registry that has been conducted across 18 high-volume European centers and specifically designed to evaluate the feasibility of coronary access. But this is not a forecast. This is not a CT-based forecast. This is a direct selective coronary cannulation of both coronary artery. We included 632 patients treated for native and severe aortic stenosis with the 4 commercially available THV valve in Europe. And actually we had SAPIEN family, Accurate Neo, Neo 2, Portico or Navitor, and Evolut Pro and Pro Plus, not FX Plus. So all procedures were transfemoral and coronary angiography was performed immediately after TAVR implantation. The primary endpoints was selected coronary cannulation of both left and right coronary artery and adjudicated by CorLab. This is the general overview of the trial.
Perfect. Thank you so much for highlighting the overview of the trial. And on that note, if you could briefly summarize the key findings of your study, sir.
Yeah, the key findings, and I think it's important for the audience to repeat this is not a forecast. This is a real cannulation of the coronary artery. So we were able to go for selective coronary cannulation, was actually more successful with SAPIEN, short frame. That means that to stay subcoronary in 89% of the cases. So it means that in 10% of the cases, when you go for very tall implantation, actually the behavior is pretty much the same of tall frame valve. So selective cannulation, 89%. On the contrary, for the tall frame, specifically the Accurate family and Portico Navitor family, 63%. 63%, and for the Evolut Pro family is 45%. In this case, we know that we have a closed cell design and we don't have any open cell in the, but the fact that in FX Plus we have this. So the point is that the primary point is both coronary artery. It's not just one coronary artery. But anyway, what we can say is that the unfeasibility of coronary access were highest for the Evolut family, 9%, close to 10%, and lowest, on the contrary, for the SAPIEN, only 2%. Among the tall frame valve, the open cell design performed better than the closed cell Evolut system, and independent predictor of unfeasibility or non-selective coronary cannulation was the use of tall frame valve, moderate to severe commissural misalignment. So the goal needs to be to go for commissural alignment and a higher implantation depth, because in this case, also the short frame behaved like a tall frame valve.
Perfect. That is so helpful for the audience. Thank you so much for going over the results. And then my last questions would be, sir, where do we go from here in terms of clinical implications for the future, and what research directions do you see from here?
So actually, I think the most important, let's say, takeaways, also in perspective, is that these findings underscore the importance of THV selection, the first THV selection, for a patient who may need future intervention, so especially lower risk patients. And also the patient that has already a CAD, that need to be assessed and to be, treated in the future. So short frame valves like the SAPIEN in this case are optimal for future coronary access, especially when you implant this valve not too high. For tall frame devices, the open cell architecture is very important, but also it's very important to get a commissural alignment to improve the coronary access. Related to the future research, I think three points I would like to share with you. First of all, we have new iteration of valve. We have the Evolut FX Plus, we have the Navitor Vision, we have the Sapien X4 in the future that include fluoroscopic marker that can improve the alignment, the coronary alignment. And the other point is to investigate strategies to optimize, to balance the optimal coronary access versus the conduction disturbances. Because we want to stay high because of conduction disturbance. But when we stay high, it's going to be a problem in terms of coronary access. And finally, it's important to explore the outcome and to generalize this finding, to extend this finding to bicuspid valves, to valve-in-valve procedure, and to other, next and repeated intervention. They need to be, assessed to evaluate exactly what might be the best permutation in a given patient, a younger patient, when you take the decision to start with the TH3.
Perfect. Thank you again for sharing your findings, and congratulations on your work.
Thank you very much.